Welcome to the 2019 CDC NTCA Recommendations for Healthcare Personnel, What TB Programs Need to Know webinar. Thank you for joining us today. I'm Kelly Musoke, the Deputy Director at the Curry Center. Today we have over 800 participants that are registered from across the U.S. Today's session is being recorded and will be archived on our website. Please look out for an email announcing when it has become available in 2 to 3 weeks. You have all been placed on mute in order to preserve the quality of the recording. If you are listening via the phone, please enter the code provided to you within the Adobe Connect link to link your phone and computer if you haven't already done so. This code is automatically displayed when you select the phone option on the audio menu and can also be located by clicking on the lowercase letter I in the upper right-hand corner. This webinar is a collaborative project with NTCA, the CDC, GTBI, and the Curry Center. The Curry International TB Center is part of the University of California, San Francisco, and is located in Berkeley, California. The Curry Center is one of 4 tuberculosis centers of excellence for training, education, and medical consultation. The Curry Center is accredited by the ACCME to provide continuing medical education for physicians. The Curry Center is also an approved provider of continuing education by the California State Board of Registered Nurses. This webinar is approved for a total of 1.5 continuing education contact hours. To receive CEUs, you must register for the webinar, participate in the entire webinar, and complete the online evaluation. The online evaluation link was emailed to all registered participants this morning, and we ask that you complete it within 1 week. Today's faculty have signed a declaration of disclosure, and additional information can be found online in our materials folder. Now it's my pleasure to introduce today's facilitator, Dr. Lisa Chen. Dr. Chen is the Principal Investigator and Medical Director at the Curry Center and is a professor in the Pulmonary and Critical Care Division at UCSF. Lisa?
Great. Thanks, Kelly, and thanks, everyone, for bearing with the little technical glitches. I'm not going to read word for word the learning objectives, but we always like to share with you what we're going to be focusing on for this training. So we will be focusing on the specific changes from the 2005 CDC TB screening and testing guidelines to the new in 2019 healthcare provider recommendation. We hope to make you aware of the common questions that public health TB programs might be fielding, and we want to help you strategize in working with your occupational health partners around the unique implementation challenges that these new recommendations might present. So just in a brief overview, we will be starting with an update on what the recommendations actually contain. We'll also be hearing from an occupational health colleague with the viewpoint of those changes from an occupational health perspective. And then what we're going to end with, we hope, is really a practical panel discussion looking at perhaps common scenarios that you may be fielding as a TB program. So with that, I'd love to introduce our presenters for today. We're really fortunate to have this lineup join us, representing TB programs, occupational health, and the CDC partnership that really contributed to these recommendations. So Dr. Lynn Sosa was the co-chair of the working group who developed the new MMWR guidance, and she is currently the coordinator of TB and STD control programs for the Connecticut Department of Public Health and is also the deputy state epidemiologist. We're fortunate to have Wendy Tanasi join us as well. She's the chief of the occupational health for the Palo Alto VA and is an associate professor at Stanford Medical Center. She's also served as the national program manager for TB for the VA system and has served as a member of the Department of VA's Occupational Health Advisory Board. Wendy is also leading the development of a practical companion handbook for implementation of these new healthcare provider testing and treatment recommendations. Finally, on this slide, last but not least in this lineup is Dr. Bob Belknap. He's the Medical Director of Denver Metro TB Program and the past President of NTCA, as well as an Associate Professor of Infectious Disease at the University of Colorado. Bob was a co-chair along with Lynn of the working group that developed these 2019 MMWR recommendations. Additional panelists who are going to be there to chime in and give us the CDC perspective include Dr. Neela Goswami, who serves as a medical officer in the Field Services Branch within the Division of TB Elimination at CDC, and is an adjunct faculty in the Division of Infectious Disease at Emory in the Department of Epidemiology at the Rowan School of Public Health. And finally, Jabril Njai is an epidemiologist with the Division of TB Elimination at CDC as well, and was the lead in the systematic review for these updated recommendations. So with that, I'm going to turn things over to our first speaker. Thank you, Lynn.
Great. All right. Well, thank you, everybody. So we're really excited to be talking about these recommendations today. So just as a reminder, we're talking about the updated recommendations that came out in May in the MMWR. But we're also going to be talking about the recommendations that we updated, which are from 2005, which I'm sure many of you are familiar with. So let's just talk about what the 2005 recommendations said in regards to healthcare worker tuberculosis screening and testing. So the summary of the recommendations from the 2005 guidelines said at hire to perform a symptom screen and IGRA or tuberculin skin test or TST in those healthcare workers or healthcare personnel without prior history of TB or LTBI. In regards to post-exposure, the recommendation was a symptom evaluation and IGRA or TST testing for those with a negative test at baseline and without TB history. And for serial screening and testing, it was recommended that healthcare personnel in a medium risk setting and settings with potential ongoing transmission have an annual test. And I think as folks are probably aware, this is where the biggest change in the 2019 recommendations is. And then finally, for healthcare personnel who were found to be positive and diagnosed with LTBI, the recommendation was for treatment referral and annual symptom review.
I've got that for you. Oh, yeah, sorry. Yeah, you can join if you want, but here's the thing.
So let me just let folks know kind of how we got to where we were with these recommendations in 2019. So these recommendations have actually, we were working on these for about 4 years, and this all started actually back in 2013. And it started with concerns about the efficacy of serial TB testing in a setting of declining TB incidence, and they were amplified during that PPD shortage in 2013. And that was also combined with the fact that we were seeing a lot of articles reporting on the poor performance of IGRA in low-risk persons. So this all led to a joint session of the National Society of TB Clinicians and the National Tuberculosis Nurses Coalition at the 2015 National Tuberculosis Conference to discuss this issue. And directly related to that, we formed our working group in the summer of 2015. We were able to start the systematic review in January 2017, and then finally published these recommendations in 2019. Okay, so as I said before, we have updated the 2005 recommendations, but as people are aware, those recommendations are very lengthy. They're well over 100 pages with multiple appendices, and if folks have read the MMWR, it's about 2,000 words. And so I just want to point out that we're focused on the first 20 or so pages of the 2005 recommendations, where the discussion is very focused on TB screening and testing of healthcare personnel. So most of the document from 2005 is actually still very relevant, and we'll be talking more about that later today. Okay, so just to give some context to how we got to the recommendations that were included in the MMWR, I want to talk a little bit about the systematic review. So a systematic review is a process in which a body of literature is reviewed and assessed using systematic methods, and the whole goal is to reduce bias in that review process and improve the understandability of that literature. This is a common process that is undertaken, and it's used to inform research policy and practice, and the whole goal is to develop or to understand what the evidence base is when we are working on guidelines. So we had 5 research questions, and I will say that they were pretty ambitious research questions. So the first question was, what is the prevalence and incidence of LTBI among healthcare personnel in the United States? Number 2 is, what is the incidence of TB disease among healthcare personnel in the United States? Number 3, does annual or serial testing via TST or IGRA of U.S. healthcare personnel reduce the risk of TB transmission in U.S. healthcare settings? Number 4, does annual or serial testing of U.S. healthcare personnel increase the detection of occult TB transmission in U.S. healthcare settings? And finally, are certain individuals who work in healthcare facilities at higher risk of TB compared to others based on either occupational or non-occupational factors? So there are many different types of methods that can be used when undertaking a systematic review, and we chose the community guide. So the other kind of big systematic review method that people are probably familiar with or heard of is the grade system. And so we purposely chose the community guide for lots of reasons that we felt it made more sense for the questions that we were trying to answer. And so we had 2 reviewers independently screen and abstract data for each of the included studies. Disagreements were resolved by consensus, and data were analyzed using R. So in our search for evidence, we focused on studies that screened or tested healthcare personnel for latent TB infection. We focused on electronic databases, the 3 that are shown here, and we started our search where the 2005 guidelines left off. So we started in looking at articles that were published between January 2006 through February 2017, and then we later updated that search for articles through November 2017. And we focused on English language articles only. So there were lots of inclusion and exclusion criteria. Our goal was really trying to include study designs that are of the best quality and trying to make sure that we were, again, had the best quality studies to have the best evidence base possible here. So this is the summary of our search results. And so we actually started out with over 1,100 articles that were identified as potentially being relevant to these questions. And in the end, we ended up with 36 articles that were included in the meta-analysis. So the summary of the findings from the systematic review are displayed here. So in short, we found that a relatively low proportion, 3 to 5%, of U.S. healthcare personnel test positive for Mycobacterium tuberculosis at baseline. Less than 1% of U.S. healthcare personnel who previously tested negative convert to a positive test during serial testing. Nearly 50% of U.S. healthcare personnel previously testing positive revert to a negative test during serial testing. And unfortunately, in these 36 studies, there was insufficient evidence to assess the incidence and transmission of TB disease among healthcare personnel. However, it is important to note that in these studies where over 64,000 U.S. healthcare personnel were included, there were no cases of TB disease that were reported. So, as I said before, we had 5 very ambitious research questions. We weren't able to completely answer those questions, and these were our findings. So what does that mean? So that means that really these recommendations are primarily based on expert opinion because we could not find a great evidence base on which to base them on. Okay, so before I summarize what the current recommendations say, I want to talk a little bit about definitions, just so that we're all on the same page. So you probably have noticed that I've been using the term healthcare personnel, or HCP, in this presentation so far. And this terminology replaces healthcare worker, and it is meant to be consistent with current HHS and CDC preferred language. So other parts of CDC and other guidelines and recommendations have already been using the term healthcare personnel for healthcare worker for the last 10 years or so. However, the definition of healthcare personnel is unchanged from the 2005 recommendations. So if you look in the 2005 recommendations, very early on, there's a list of all the different healthcare personnel that should be considered when determining if they should be included in a TB screening or testing program, and we have not altered or changed that list in any shape or form. So secondly, I wanted to define TB screening and TB testing. So TB screening is the broad process that includes a risk assessment, symptom evaluation, a test for latent TB infection, either a skin test or an IGRA, and additional workup for TB disease as needed. And then when we're talking about TB testing, we are specifically talking about the test, the IGRA or the skin test. Okay, so what are the major changes in the 2019 recommendations? So first, when we're talking about baseline or pre-placement testing, and so pre-placement is a term that our occupational health colleagues use, and so that's why we included it. We are recommending an IGRA or a skin test with symptom assessment and an individual TB risk assessment. And the addition of that individual TB risk assessment is a new recommendation. For post-exposure evaluation, we are still recommending a symptom evaluation and IGRA or skin testing for those with a negative test at baseline and without TB history. And this recommendation is unchanged from 2005. In regards to serial screening and testing, we are not routinely recommending any screening or testing at any regular interval. However, routine annual testing can be considered for certain healthcare personnel groups, and we'll be talking more about that in this webinar. However, we are recommending annual TB education of all healthcare personnel, and this education should include TB exposure risks. And finally, for follow-up of LTBI positive healthcare personnel, we are strongly recommending that these healthcare personnel are treated unless a contraindication exists. All right, so let's talk a little bit about each of these recommendations a little bit more in depth. So for baseline pre-placement screening and testing. So as I said before, this screening on hire at pre-placement should include a TB risk assessment, a symptom evaluation, a TST or an IGRA, not both. However, the goal of having the TB risk assessment is to be able to better interpret the results of that skin test or that IGRA. So if the healthcare personnel who test positive is low risk on that TB risk assessment, they should have another test. And this is not a new recommendation. This is consistent with the TB diagnostic guidelines that were recently published in 2017. Okay, and again, just to go over post-exposure screening and testing, which is not a new recommendation. So here we are talking about a known exposure without adequate personal protection. So we wanted to be very clear about the scenario that we're talking about here. We're talking about healthcare personnel who have no history of a positive TB test. And for those healthcare personnel, they should have a symptom assessment and TB test at the time the exposure is recognized, and again, 8 to 10 weeks after the last exposure. For those healthcare personnel that have a history of a positive TB test, regardless of a history of treatment, they should have a symptom assessment, but they do not need another test. Okay, so this was one of the biggest changes from 2005. No routine testing of healthcare personnel at any interval in the absence of known exposure or ongoing transmission. Now, healthcare facilities can choose to conduct routine testing of specific healthcare personnel groups. However, I want to very clearly state that most healthcare facilities don't need to do this. So for example, in Connecticut, whenever somebody calls me and asks me if they should be doing any kind of routine testing, I say no. And this is something we'll be talking about later. It is very important that this type of decision be individualized to each facility, and it should be done in consultation with the state and local health department. Okay. So a little bit more about the TB education. So it is certainly, we all recognize that non-occupational exposures are really important, as well as individual healthcare personnel's risk factors for potential TB transmission, progression, So it is really important that facilities educate healthcare personnel annually about tuberculosis. And this health education should include risk factors, signs and symptoms, and certainly if a healthcare personnel recognizes that they've had new exposures, either occupational or non-occupational, they should be encouraged to discuss those either with occupational health or with their primary care doctor. And any decision to test a healthcare personnel in these scenarios should be based on any individual risk that is identified. Okay, so what happens when you have a positive test result in a healthcare personnel? So a healthcare personnel with a positive TB test needs to have chest imaging, symptom assessment, and further evaluation for TB disease if that's warranted. And then really important, all healthcare personnel with LTBI should be offered and strongly encouraged to complete LTBI treatment unless a contraindication exists. So this was the table that was included in the MMWR, which neatly lays out side by side the 2005 recommendation for each of kind of the four major categories that we were talking about, and then the 2019 recommendation, and whether that was a change or unchanged from the 2005 recommendations. So finally, I just want to thank all of our work group members. And as was kind of mentioned previously before, we had a lot of different partners as part of this work group. We had CDC partners, not just from tuberculosis, but from NIOSH and DHQP. We had TB subject matter experts, infection control, occupational health, and so we're really proud of the group that worked on these recommendations. So next, I will pass it off to Dr. Wendy Tanasi. Thank you.
Good morning, everyone, and thank you very much, Dr. Sosa. That was fantastic. It doesn't leave me with all that much to say. I think you did a phenomenal job. Thank you to everybody who's taken your time to listen today and to learn about these important changes. Thank you also, of course, to all the colleagues who worked on this. As Dr. Sosa mentioned, I've been spearheading the 2019 companion document, which is supposed to help occupational health providers and hopefully some public health providers as well to operationalize the new recommendations. This again was a collaboration. So where the main MMWR was a collaboration between NTCA and CDC folks, the companion document is a collaboration primarily between NTCA and ACOM, the American College of Occupational Environmental Medicine, which means that the companion document will be published initially in JOEM, the Journal of Occupational Environmental Medicine, as a special task force paper, and we're considering whether we'll publish it elsewhere as well. But the initial coming out will be JOEM. Let me go through quickly some of the things that Dr. Sosa mentioned to you. On pre-placement, there is one major change, which is the inclusion of an individual risk assessment. So all healthcare personnel should have baseline TB screening, including an individual risk assessment. I emphasize the word individual because there's confusion sometimes with the facility risk assessment, which is done by infection control and which is appendixes B and C of the main MMWR 12-page tome on looking at the environmental protections available in the hospital. The individual risk assessment is about occupational health, looking at the person and their risks. And as Dr. Sosa said, it's done so that one can interpret the results of the test better. If there's a low positive in somebody who came from a high-risk country and had been previously PPD positive, that is a very different situation than someone with no risks. And who to do a risk assessment on? The individual risk assessment is done on everybody at pre-placement because it should not be done annually. I need to reiterate that. The individual risk assessment is not to be done annually. The GINA law of 2005 is Genetic Information something Privacy Act. So that occupational health providers are not to use private information in decision-making about the application of regulations. So let's say you have a population of people who were born in pick a country, Mexico, Philippines, Vietnam, a higher risk country. If you apply that individual risk assessment annually to a subset of your population of employees, you are breaking the law. So the individual risk assessment is to be applied equally and only at higher. The privacy around it is really important. If one were to do an individual risk assessment on a subpopulation and sends it to their supervisors and says, oh, only this population needs the annual assessment, that again is a privacy violation. So everything needs to be applied equally, and the MMWR recommends we do it only on higher, remembering that those risks likely don't change. I will add also, what are you looking for in this annual risk assessment? If you were to do it annually, you would be asking private information about maybe what they're doing on weekends or why they're traveling. Those are occupational health violations. So how often do we do the individual risk assessment? Once. That can be on hire, or it can be when someone is transferred from a non-clinical position into a clinical position. One other thing Dr. Sosa mentioned that sometimes can be in conflict with the way we practice is when to repeat a previously positive test. So where the MMWRs, both the new one and the old one, say you don't need to repeat a previously positive test when you're hiring someone, actually in practice, occupational health can choose to do so and does so in many circumstances. Often this is related to workman's compensation, but sometimes it's also related to the type of test. So if your healthcare provider comes in and they haven't had a TST since they were a child, and at that point it was positive, and they never had a confirmatory IGRA, and maybe they were BCG vaccinated, you don't have to take that as a positive test. Your occupational health providers may decide to go ahead and repeat that test with an IGRA and get more updated information. Similarly, perhaps an older generation IGRA was used before they were hired, so you might want to use the more updated version that your hospital is using for consistency throughout their employment. And it could be that their TST was positive in somebody who never had any risk factors, and they come into you and they're like, yeah, doc, I was positive, but there was no reason. In that case, occupational health could decide to repeat their testing on hire. To continue with serial testing, this is where the biggest change took place, and this is where we're very excited. The healthcare personnel should not undergo routine serial TB screening or testing at any interval of time unless there is known exposure or evidence of ongoing TB transmission. This is an enormous and important change. Occupational health providers spent countless tens to hundreds of thousands of hours per year of their time and energy and money doing testing on a population that's 97% negative. So let's see what that means. Sometimes I hear an echo again. Is this better now? So if you can hear me well enough, the serial screening has been eliminated, as Dr. Sosa said, because what we found is that in the data, healthcare providers are not getting TB and don't carry TB at a higher rate than the general population. So when the CDC did a study in 2016 based on occupation, they found that only 3.4% of all active TB cases in the U.S. were in healthcare workers. That means even though we're doing 18 to 20 million tests per year, if only 3% of the cases are in healthcare workers, 96.6% of TB is not in healthcare workers. So clearly we're looking in the wrong place for TB, and all of our national healthcare dollars and our public health efforts should be shifted to the place where TB is rather than where TB isn't. Another nice study that I'll go over quickly is just that from 2003 to 2007, the rate of TB in healthcare providers was lower than that of the rate of TB in the U.S. population overall. In another section between 2010 and 2016, the rate in healthcare providers is again lower than it was in the U.S. total. So for any of you who meet resistance or concern from hospitals about stopping serial TB testing, please reassure them with some of this data that will be available to you later. It's not surprising, right? Healthcare professionals are generally educated. They're not at the extremes of life, but in being infants or the elderly. They're generally nutritionally adequate. So they're not the population who should be at risk for tuberculosis. So this does make logical sense. Now that we're not getting TB from our patients, healthcare providers are in fact a healthier population than the overall U.S. population. As Dr. Sosa alluded to, the facility risk assessment has changed in that Those facilities that are deemed medium risk on the facility risk assessment are no longer linked. You can see the no with a circle to annual testing of healthcare providers. So a facility can still be a medium risk facility, but just because the facility is medium risk does not mean that the employees get annual testing. That's perhaps the most important change in the potential for ongoing transmission category. If those employees are working in an area where there are inadequate environmental controls, there's not adequate air exchanges or masks available, or other evidence that there's been any ongoing transmission, one should consider keeping those individuals working in that situation in an annual testing situation. Post-exposure, the main change here, as Dr. Sosa mentioned, is that the definition of exposure has always been a problem for healthcare personnel. So where they helped us a great deal was adding without adequate personal protection. Because really, when patients are masked or employees are masked or they're put in air-negative rooms or they're seen even in major U.S. facilities, generally those employees have not been exposed. So that language was added to help us. I do want to also mention that we do tests. Well, I think I bring this up later. This isn't to say that we minimize the risk of employees being exposed to TB. It will continue to happen since TB is in the U.S. And when it happens, it can be a major disaster. In this paper right here in Loma Linda, they had over 1,700 patients exposed. These are not by other patients. These are by healthcare personnel who reactivate. So where 80% of the TB cases in the U.S. occur, they occur in reactivation TB. So if occupational health is doing their job and public health, please help us. When we identify on hire that these people have TB, we need to be treating them and not testing them every single year. When an employee exposes patients, it ends up being a massive exposure investigation as opposed to small ones that occur when patients come into, say, one or two areas of your hospital with TB. Again, Dr. Sosa mentioned that we don't do a test on people, on our employees post-exposure. We actually do in occupational health in many situations. So if that employee had a prior positive but is now exposed to TB, it can be required by your workers' compensation carrier that you check their status before, as you start your exposure investigation. Again, if you hired that employee 20 years ago and all they had was one positive TST, it wouldn't be fair not to test them immediately post-exposure. You want to test them and find out with an IBRA whether they're truly positive or negative, and then follow them 10 to 12 weeks later and see if they converted. So there are a few situations where when you're doing a post-exposure investigation, early in that investigation, you do repeat previous positive tests. And in order to save time, you can refer back to this slide. On the education and prevention, this is super important. Healthcare personnel should receive annual TB education, and what that includes is the risk factors and signs and symptoms of TB disease, because they're not being tested annually anymore. But really, it's the treatment options and where to go for treatment that we really want your employees to know. I want to hand this microphone over to Dr. Belknap really soon. So I want to mention that our public health colleagues and our occupational health colleagues have done a phenomenal job in decreasing tuberculosis in the United States. We're down to about the final 10% of elimination. That means we're no longer targeting active cases, we're targeting latent cases. So when you can identify people with latent TB, if you can treat them, we will get down towards the final steps of elimination. So the testing that we've done on 18 million healthcare workers, all that testing every single year, that didn't prevent disease. It didn't treat the disease. It didn't help eliminate the disease. It's the treatment arm that's going to prevent its spread and is going to treat it and is going to help us eliminate TB in the U.S. There are some wonderful resources that we'll have in the companion document and NTCA has available on their website. This is a front-back form on 3HP, the once-a-week for 12-week antibiotic treatment for latent tuberculosis. There will be some figures in the companion document where you can hand out to your positive patients, some different options for short course and other treatments that are currently available. The final public service announcement is that when we were testing 18 million healthcare workers, it then bled to teachers and coaches and babysitters and bus drivers. For latent TB, every single year, we were creating an incredible amount of carbon waste. These tubes are produced in Austria, and then you can see the carbon footprint that goes before they even get to my VA, and then the test is done. When you do a T-spot, you then fly that test back to Memphis again. So planes, trains, and automobiles all creating carbon waste with tens of millions of tubes, needles, and garbage. And I bring this up because we do have to think on this, not only on a national public health level, but on a global public health level now about the decisions that we make. We did all of that with results that were negative. So eliminating serial testing and focusing on treatment is going to save the U.S. and the planet in more ways than we even know. Thank you very much.
Thank you, Dr. Thanassi, for going through that so carefully and for your passion for the last several years on this initiative. I just wanted to spend 1 or 2 minutes highlighting some of the educational materials that we have out of Division of TB Elimination here at CDC on behalf of our communications colleagues. As you all are realizing, this guidance has come out, but the real work is going to be in the implementation, and we're going to be depending on all of you joining us today to help with that effort. So to empower you, please use the tools that we've got available to you. The guidelines itself, as Dr. Sosa mentioned, are brief. We're talking about a two-page double-sided document that you can get here at the cdc.gov website that you'll see on this next slide, and that's the MMWR. Again, on behalf of my communications branch, we also have a direct link to the baseline assessment form as you explain that to other colleagues who may be asking about this. There's a nice frequently asked questions site, and there's updated web content on healthcare settings and healthcare personnel testing that you'll see. For those of you who aren't as excited about all of the written materials, there are some nice visuals as well. We've got an overview video, a Medscape CDC expert commentary, and a visual infographic. And as I mentioned, you can find all these materials at our www.cdc.gov/TB website. You can also retweet or share social media content from Twitter and Facebook. And with that, to help us go through some of the nitty-gritty of the clinical scenarios you all may be faced with, I'm going to hand it over to Dr. Robert Belknap. Thanks.
Thank you for that. Those are great, some great places to find resources, and thanks to Lynn and Wendy for presenting. And so I get the pleasure now of taking us through some scenarios that we've put together based on examples of questions that we've already received, and some of you may have received as well. This is also the opportunity for you to participate, and it's great. We've been getting questions coming in through the chat. We are tracking those. Some of them we're going to, I think, answer as we go through some of these scenarios, and the ones that we don't, we'll try to address in the Q&A. And if we run out of time for all of that, we'll do our best to put together some responses after the webinar to all the great questions we're getting. So that takes us to scenario 1. So a federally qualified health center that provides primary care to mostly uninsured patients, with over 50% who were born outside the U.S., contacts you and asks if they should continue doing annual TB testing for their healthcare staff. They do not have an active contact investigation or evidence of ongoing transmission. And so the polling question for all of you, would you advise them to continue doing annual testing? Yes, because they care for a proportionally large population at higher risk for TB. No, annual testing is no longer recommended. Focus on LTBI. Or maybe, I don't know, I need more information. We'll give you all about 30 seconds to think about that and log your answers. All right. Thanks, everyone who replied. Most folks said no, no annual testing, but we had a mix. Some people that thought yes, and some that said, I'm not sure, I need more information. So, Lynn, let me start with you. For as someone working in Connecticut in the TB control program, what additional information might be helpful in this situation?
All right, thanks, Bob. Can you hear me? Uh-oh.
I hear you fine.
Okay, great. So I think what I would want to know more from this federally qualified health center is what is their TB infection control policy and what administrative and environmental controls that they have in place. So for example, do they have a really strong policy about any patients that come in with respiratory symptoms and making sure that they put masks on them right when they walk into the facility, so they have masks available, or they have signs posted about covering cough and things like that. Do they have airborne isolation rooms available? Do they have a really good policy that when people have respiratory symptoms that they don't let them sit in the waiting room for a long time? That's the type of information that I would be really interested in, because if they have those types of controls in place, those are the things that actually prevent TB transmission in these types of settings. So if they have those in place, I would be much less concerned about somebody coming in with respiratory symptoms that could be TB and those not being recognized because they had these other things in place that would be able to remove that person. But if they've had issues with that, they recognize that that's a problem, or maybe they don't have a good TB infection control policy in general, maybe that's a place where we would then have a little bit more conversation about why they might want to continue TB testing or where that might be helpful. But kind of just understanding kind of what their basic infection control policy about for TB is going to be really helpful in me giving them recommendations.
Great, thanks, Lynn. So, Neela, let me ask you, as the medical officer and our CDC representative for this webinar, does it matter, and do you need to know what the TB incidence is in the jurisdiction for this federally qualified health center that's contacting you?
Hi, Bob. No, certainly it's a good question, and there was a bit of discussion on this when the guidelines were being crafted. Of course, local epidemiology, how many TB cases there are in a jurisdiction, should be taken into consideration as part of healthcare provider and personnel training, because this helps keep TB on the differential when folks are seeing patients with symptoms consistent with TB, and also maybe to help inform how aggressively various environmental controls should be in place. And of course, at CDC, we always strongly encourage close communication between clinic administrators and their local and state TB programs when making these kinds of policy decisions. But all of that said, you need to know the TB incidence in the jurisdiction when making a decision about serial healthcare personnel testing. And the answer to that pretty clearly is no. And as counterintuitive as it may sound, there's not an automatic association when we see a high TB incidence in a jurisdiction and high TB transmission among healthcare personnel at clinics working in various parts of that jurisdiction. It's really important to recognize that individual clinics and personnel working at those clinics can have really heterogeneous risk profiles across even a high TB incidence jurisdictions, to the point that we can sometimes even see the opposite. We can see that if there's a county with a lot of TB patients, implementation of infection control programs in those regional clinics may sometimes be more rigorous. That is, they may be better with their airborne precautions when appropriate, have better availability of N95 masks or isolation rooms, et cetera. And that may lead to even less transmission than perhaps a sister clinic in a low incidence jurisdiction. Of course, there can be areas with a lot of TB, and poor infection control measures and serial testing may come up for consideration there. But in other words, appropriate healthcare facility infection control measures, like those environmental and patient-centered measures solidly in place, may be more important to take into consideration than just absolute high-level numbers of TB cases at the jurisdiction level alone.
Thanks. I guess along those same lines is the next question was, well, does it matter where they're located? So it's sort of same situation, but the clinic is located near the U.S.-Mexico border. Would what you just said change at all?
Not really. You know, and again, we wouldn't necessarily focus on clinic location. Instead of clinic location, what's important to consider here is the presence of those
infection control measures, and specifically looking at the facility risk assessment. Now, if there's issues, and we've heard, different things perhaps about border pop-up clinics or places where isolation of patients with infectious TB might be challenging, that's certainly a unique situation where there might be different considerations at play. But by far and away, serial testing for healthcare personnel is not what we are now recommending across the United States. And the most important thing to keep in mind is that we recommend focusing on identifying and testing patients with symptoms for active TB disease, implementing appropriate infection control procedures, and of course encouraging TB prevention by testing and treating latent TB infection. We need to prioritize those public health interventions that have been shown to have the greatest impact on halting TB transmission and preventing progression to TB disease.
That's great. Thanks, Neela. And for the last one, I want to turn back to Wendy, who's our occupational health expert on the panel. Wendy, what if healthcare personnel, had to be tested as part of a contact investigation the previous year? Is that someone that you think should be then receiving annual screening?
Thanks, Dr. Belknap. Certainly being part of a contact investigation once a year is not of concern. I would say if you are working in some place like one of these pop-up border clinics without adequate control and you are being exposed to TB constantly, it is troublesome to be doing exposure investigations every 6 weeks. And in that case, you might do better to revert to annual testing. It's something that we've been talking about and is tricky. Really, the most concerning thing is if an individual is in an area where they're being repeatedly exposed, the environmental controls must be looked at. What is the air handling? What is the masking policy and procedure? So what we're going to recommend is probably if you're in a situation where you're having more than 2 active TB contact exposures per year in that individual healthcare provider, we might have that individual healthcare provider recommended for annual screening. And in that case, I would have OCHealth work with your public health colleagues to come up with the best plan.
That's great. Thanks, Wendy. So just to summarize, so the scenario was you get contacted by a federally qualified health center asking if they should continue to do testing. The best answer really is no, that they should be focusing on ensuring that anyone that's infected is completed treatment, and then also making sure that they're paying attention to their administrative and environmental controls. The additional information that was talked about may help frame discussions, but it really is highly unlikely that there's a facility that is routinely detecting unrecognized TB transmission through annual testing, not through contact investigations, but routine serial testing. And if they are and haven't addressed that, that's the bigger problem. Most of the variability when people say, well, but we see conversions every year, yeah, that really is because we have imperfect tests, and we know that if we test a group of people over and over who are relatively low risk, we're going to see random positives, and those are really consistent with false positives. In a big study of healthcare workers published in 2013, this sort of random positive was less than 1% with the skin test, but about a 3 to 4% with quantiferon and the T-spot. So, if a facility contacts you and they really say, oh no, we see a higher rate of conversions than that, known variability, then our recommendation would be focus on trying to identify and fix the administrative and environmental controls as much as possible. But in that rare case, if it's occurring, and the pop-up clinics, Wendy, that you mentioned might be a great example. If you've got a place that they can't fix or don't have good environmental controls, then maybe in that rare scenario it makes sense to continue annual testing. So I'm going to keep us moving in the interest of time and trying to keep on, give a little bit of time at the end for question and answers. I'll take us to scenario 2. So an occupational health provider calls and asks, what are they supposed to do with the individual risk assessment, and can they stop doing the facility risk assessment? So what would you tell them in that case? Would you tell them that the individual risk assessment is important for interpreting the tests, or the facility risk assessment is important for determining environmental and administrative controls? The individual risk assessment is optional, and may be helpful. The facility risk assessment is still important to decide who should continue getting an annual TB test. Both risk assessments are required and should be performed every year, or the individual risk assessment is the only evaluation that's recommended now. The facility risk assessment is no longer necessary. Again, I'll give you 30 seconds to think about that and respond. All right, I'm going to end the poll, and we'll look at the results. So most people felt number one was the right answer, but again, we had a mix of people for the other three. So I'm going to go back to some questions related to this and to our panelists. And so, Lynn, let me turn to you first as one of the co-chair for this. What is the purpose of that individual risk assessment?
Thanks, Bob. So we included the individual risk assessment, as we've said before, primarily because we thought it was important for interpreting that initial TB test result. So as I've said, at pre-placement, we're recommending a symptom assessment and a TB test, an IGRA or a skin test. And we thought it was really important to have that individual risk assessment so that you can interpret that TB test result. So, for example, say you have a healthcare personnel who's starting work and they just came from the Philippines, never had a TB test, and so that person is clearly from a high-risk country, their TB test is positive. Okay, done, that makes sense. This person has a TB risk factor, and we're going to move forward with the appropriate evaluation for that person. But most healthcare personnel in the United States don't have any TB risk factors. So say we have that same person, same age, same gender, and their test is positive. It's really important to know that, hey, wait a second, they're from the United States, they haven't traveled anywhere, they don't have any immunocompromising conditions, and their test is positive. That kind of doesn't make sense. And so that's a situation where a second test is recommended to really confirm that first test and say, okay, do we really think this person is infected? Because if they are, we're going to do a chest x-ray and we're going to recommend treatment. So that was really the impetus for including it. And so I think the other thing I'd like to say is that we included basically the TB risk assessment that our colleagues in California have put together because we felt that it addressed the major question, and it's very simplified, but it is not necessarily meant to be the end-all, be-all risk assessment. So I hope that's helpful to people.
Thanks, Lynn. Wendy, what are some challenges occupational health providers might face in implementing this individual risk assessment?
Thanks, Dr. Belknap. So I know that there was some echo earlier, so I don't want to take too much time, but we do need to implement individual risk assessment in an extremely fair and equal manner so that it can't be given to just one population. If you're doing your pre-employment risk assessment, it cannot be given to just one population of your pre-employees, like, say, Dr. Sosa said, from just people from the Philippines or just people who have been incarcerated. The other thing is that it must be kept, obviously, completely confidential, including from supervisors. So it shouldn't be sent out and returned by any personnel who are not in your occupational health group. It also, I would say, I think that's the most important thing, is that it's applied very equally and that it's kept completely confidential within the realm of occupational health.
Great, thanks. So let me ask Neela. Neela, is there still a need for the facility risk assessment, and if so, why? Why do we need to do it?
Yeah, the facility risk assessment is very much an important tool that's required to assess if a facility has the appropriate level of administrative and environmental controls. The distinction here is that in the original 2005 CDC guideline, this assessment was recommended to be used to determine if annual TB testing was needed. But the assessment is no longer recommended for this indication. It's now globally part of a good practice that a facility should undertake as part of an infection control program. Certainly, participating in the facility risk assessment could be used as part of annual education to staff and for other reasons as well.
Great, thank you. And so, I think one of the other questions that we've heard from folks is, why is treatment being emphasized now? And in Wendy, in your presentation, you highlighted that really what the large exposures that have been seen and have been reported in sort of recent memory have all been exposures in healthcare settings from healthcare workers, most or all of whom were known to have latent TB infection. So these guidelines are meant to minimize the risk of TB exposure and to prevent TB exposures in healthcare settings. The best way to do that is to treat the people we know have TB. We're going to have patients that come in and they weren't in care or they didn't get screened and now they have TB and exposures may occur and lead to contact investigations. Some of those are unpreventable, but if we have healthcare workers with known latent TB infection, boy, that's an opportunity to benefit that individual and their health and minimize the risk wherever they work in healthcare in the future. So that's really the reason why this wasn't a new recommendation; it existed, but we emphasized it in the update. And really ask that and think that occupational health providers should have a larger role in trying to ensure that people get referred appropriately, offered, and treated for latent TB. So again, just to summarize on scenario 2, what to do with the risk assessments. Really, the best answer was number 1. The individual risk assessment is very important for interpreting those baseline TB tests. It's not recommended as an annual screening, although I've been told that some facilities actually do some annual assessments, and so we're not telling people not to do it, but it's not part of the recommendation. The facility risk assessment really is important and is still, we didn't change, it wasn't addressed, it wasn't changed in the update, so the 2005 guidelines still exist. The only change is that the facility risk assessment should no longer be used to determine if any groups need to be routinely tested. Its utility is for determining if the environmental and administrative controls are working properly and adequately in place. That brings us to our last case scenario. So a friend who's a pulmonologist at a local hospital asked if she should continue to get an annual TB test because she regularly does bronchoscopy. So what advice would you give her? Would you tell her that her job's high risk and she should definitely continue to get a test? It depends on how many patients with TB are diagnosed at her hospital each year. It depends on how many patients she personally sees who gets diagnosed with active TB, or she does not need an annual test. So we'll give you 30 seconds to think about that. All right, I'm going to end the poll and show you the results. So this is great. We got a much wider spread of what people would recommend to their friend, the pulmonologist. So, getting back to our panel, Lynn, let me start with you again. What would you say that the 2019 guidelines would recommend for this person, and what advice you would give them?
Sure. So first, a little context for the flexibility that we've put into the recommendation in this regard, because generally we're saying you really don't need to be doing routine annual testing of any healthcare personnel, but we recognize that there might be certain groups or certain situations in certain facilities where, for example, environmental and administrative controls are not well implemented, and that might be a situation where a facility would consider doing annual testing. And so we thought it was important to recognize those particular scenarios, but again, those situations and those recommendations really need to be done on a facility-by-facility basis in conjunction with state and local health department. So I think we included, just as, again, an example, not meant to be the only groups. I think we said pulmonologists and respiratory therapists, but I think we also recognize, for example, that emergency departments are sometimes places where infection control in regards to TB is an issue. So I think in this situation, I would really want to understand, what their policies and procedures are in regards to infection control during bronchoscopies. So I am not a pulmonologist, but my understanding is that when bronchoscopies are performed, there's supposed to be a certain level of infection control. And ideally, if TB is ever a consideration, and then pretty much any bronchoscopy specimen I've ever seen is almost always tested for TB. So if that's the case, they should be using it, be fit tested, using N95 masks, and having appropriate infection control in place. So if that's the case, I would not be recommending annual testing for my friend the pulmonologist.
That's great, and thanks for bringing up, that there is intentional flexibility because we knew we couldn't predict every scenario that might occur, and so we wanted occupational health to have the ability to make these decisions. And I think that was one of the constraints that people expressed related to the 2005 guidelines. They really felt like they were locked in based on the facility risk assessment. So thanks for that. Wendy, can you think of any scenarios where you would recommend annual testing?
Hi, everybody. Thanks, Bob. Hi. No, I think we've been through that. I think the annual testing is very important in settings where there's evidence of ongoing transmission. So where someone has been doing annual testing with a population and they are seeing that there are conversions, we would never want to miss that there's ongoing transmission in that area, and annual testing with that individual group would make sense. Otherwise, as Lynn has said, the issue of a specific occupational group, and as your question points out, whether it's pulmonary or ER, other groups, there's no data that supports that a category of employees has been having ongoing transmission. So within your facility, if there is that population, please continue that. I suppose another group that has come up in the chat is there are healthcare workers who work overseas in the course of their duty. So if you're assigned to work in Ghana for a month or two a year, that might be a population that makes good sense to keep in an annual screening population. That does not go for people who travel for personal reasons. So if they go to visit friends and family, that's not an occupational health. That's not in our purview. That's something primary care physicians should be working on. But if they're traveling in the course of their work duties to high-risk areas, one might consider that. And that travel, as defined by the California Department of Public Health, is for over a month at a time. Does that help?
Yeah, that is. Wendy, let me ask you this, because part of the annual education said to talk about, to educate people about non-occupational risks. So if a person was traveling, say not related to their work, and they wanted to come in and get tested, would occupational health want to know about that, and would you do testing if someone showed up and said, hey, I just wanted to let you know I was traveling and volunteering in a country where TB is common?
I love that question, and I can't answer it because every facility is going to be different. In the Palo Alto VA healthcare system, we don't ask questions about why they want a TB test. That breaches their confidentiality, but if someone comes to us and says, I'd like a test, I think I may have been exposed, I go ahead and do it. In other facilities where money is tighter because occupational health is an underfunded area, they may decide that if that risk was a personal risk, it has to be taken care of by their primary care providers. What we'll recommend in the companion document is that occupational health approach annual testing as voluntary without the questions associated with it. So if an employee just says, I'm worried I was exposed, we would like that they offer the test, but we certainly can't mandate that because it is a private medical issue. Does that make sense?
Yeah, absolutely. Thanks. That's great. And so the last question I have for this one is one that was brought up in the chat as well. So Neela, what about correctional care workers who may be required to get an annual TB test? How do these recommendations, or do these recommendations apply to them?
It's a good question. You know, while these guidelines cover a lot, they are narrow in the sense that they only apply to healthcare settings. Now, if a correctional care worker has a healthcare-related position and that's the only reason they're getting tested, then these guidelines would apply. But we have to be a little bit careful about who we would be generalizing this guideline to outside of the healthcare setting. Keep in mind that there are occupations like coroners and skilled nursing facilities, and correctional workers may fall into this category as well, where there very well could be patients where TB is suspected, but diagnosis can be particularly challenging. And so in that area, that makes it a little bit distinct from employees working in the healthcare setting.
Great, thanks, Neela. So I'm just going to go through some conclusions, and then we'd like to follow up with some Q&A. And so, you know, the new recommendations that are an update to the 2005 guidelines say that we really should be focusing our efforts on the baseline testing that now includes the individual risk assessments for the reasons discussed. Really encouraging healthcare personnel with latent TB infection to complete a course of treatment, and educating all staff to recognize the symptoms of active TB and also the risk for potential non-occupational exposure, so living, volunteering, providing medical care in a country where TB is common. All of those are potential risks, and if someone has those, as Wendy, as you said, the occupational health providers can't really ask about that, but you know, making it known that people should get tested. If occupational health can provide that testing, great. If not, then they may need to get tested through their primary care providers. Another question that's come up a lot in the chat, and we've heard a bunch, is, you know, do these guidelines replace any existing you know, local or state regulations? And the answer is no. The CDC guidelines and recommendations are just those. They're guidelines and recommendations. Then it's, you know, local regulatory bodies and national regulatory bodies like OSHA that use the guidelines to set the requirements. And so depending on where you're living, you know, there may be laws in place that say that healthcare worker or testing of healthcare personnel annually is required. And so what we're encouraging people to do is to really use this update as a tool to go to whoever it is that controls those legally, and, you know, educate them that the laws in your jurisdiction are out of date relative to the actual risk, and work to get those changed. And lastly, it's been mentioned a few different times, but there is a companion document that is focused on implementation and covers a lot of the things we talked about today, but even goes into greater detail and more depth and more scenarios than we could present on this webinar. And so that will be coming very soon, and once it's available, we will be advertising it so that everyone participating on the webinar and beyond will know when it comes out and have access to that as well. So with that, I'm going to turn it back over to Lisa, who's going to moderate our Q&A session.
Well, great. Thanks to all of the presenters. You guys have to know this is just a start. This is a fabulous start. We really thank you for your expertise. There's been really a healthy number of questions, in the chat. And I know that many of you actually turned in questions ahead of time during registration. And what we're going to do with these is, certainly we're going to try to answer a few now. Hopefully some of the questions that you had before the webinar got answered during the discussions already. But we're going to circulate these questions and see if some of them can be answered by our faculty, and we're also going to use these questions and pass them on to our partners, particularly NTCA and the other centers, the COEs, and hopefully we'll have a series of webinars that will help with this, especially when the companion guide comes out. And I'm just going to throw that out there really quick once. Wendy, people were wondering, is there a timeline for when you think the companion guide might be out?
Hi, Lisa. Can you hear me now?
Yes. Great.
Yeah, it was June 16th, 2019.
Oh, no, when the companion document that you're working on?
That was when it should have come out. So the goal was that it come out 1 month after the publication of the MMWR. We've been held up by a lot of really good input from a lot of other groups, and so we're working actively with colleagues across the country, whether it's TB and public health, whether it's laboratorians, to make sure that their questions and answers are heard and addressed. We're very close to finished, but every time I think it's done, it's not quite. So I'll keep going with really soon, I hope.
Great. Thanks, Wendy. And so we do want people to have a chance to even join in this. We don't have a way to pick two answers first, but if you'd like to call in, press *6 if you're on a phone line, and start to speak out, and we will give you some time with the panel right now. And so while we're waiting *6 in, I'm going to go ahead, and I know that the panelists were even pointing out to perhaps talking about the question of Maureen. We see recommendations regarding testing general. I think, Neela, you thought that maybe you take a stab at that first?
Hi, Lisa. I'm so sorry. It seems like you were going in and out a little bit. Was this the question about traveling?
No, about recommendations. When are we going to see recommendations for the general public?
Oh, yeah. No, a lot of folks are asking, and I think Bob alluded to this at the end. A lot of folks are asking, do these trump my current regulations that I've got in place, and or when are we going to see some changes beyond healthcare workers? And I just wanted to comment that, at this point, we're starting with the document. It's certainly taken a lot of work and a lot of input from a lot of stakeholders, but truly the next step is most important, and that is for this guidance to then make its way into all of the local regulations and state policies that you all work with closely. And so I just wanted to make that comment that that a lot of questions are arising about, hey, how long is it going to take for this to then percolate to a level where I see it? And I just wanted to turn that around back on everyone who is joining and educating themselves about this document, because here's where we're passing the torch for everyone to help in this real widespread implementation.
So I think then that would apply to some of the questions around laboratory folks, other long-term care facilities. That's exactly what you're trying to pull out. I know, I'm sorry, folks, I do hear that echo in the background. We haven't been able to figure out. Is there anyone on the phone line? *6 to unmute and ask a question. Okay. If not, one of the questions that are coming up, I'm hoping there were quite a few questions on California regulations, Cal OSHA, I know that there is a group from the California DPH on. I don't know if you have a phone line and could *6, but there were several California-specific questions coming on. We'd love to hear your thoughts on when you might see changes for California. Well, we're waiting to see if they can unmute themselves. Maybe I can see Wendy is going ahead and answering some of these other questions, but Wendy, maybe you might want to just come online. You're talking about baseline testing for students and others who are bouncing around between different facilities. Would you like to go ahead and chat about that here? Go ahead and unmute yourself, Wendy.
Sure. Do you hear me now?
Yes.
Great. Yeah, that was a good question. And what we have at the VA with our thousands of hospitals is the issue of transfers. So our where we used to do TB testing for transfers, we're just now, thanks to the MMWR, stopping doing that TB testing. You know, that's really ends up being a workman's compensation issue. If it's a private hospital whose workers' compensation requires that they be tested before they come in to prove, you know, that they were positive before they came into your institution, you may be mandated to continue doing all this testing with the bouncing around. But in terms of what's medically and fiscally responsible, we're not seeing that people in the healthcare field are converting. And so if you are able to make that decision, then no, people bouncing between different institutions, as long as they're all relatively low risk, which almost everyone in the United States is, they do not need to have repeat testing. That's going to be, though, a facility decision more than it can be a policy decision.
So I think that goes to some of the questions that have happened, a blended set of questions. If you've had a test at another facility, and I guess the scenario, you've got it documented, then if you bounce to another one, you could just show that documentation and you're fine, correct? That still stands true.
That is true if that facility's workers' compensation accepts older tests. So in my facility, it used to be 90 days at the VA, and we just wrote the guidelines to 12 months. So at this point, if a previous test was done within the past 12 months, we accept it. We may move that to being forever. That's a tough question to answer. We have to make pre-hire, that at pre-hire, the occupational health is comfortable with the situation they're in.
Yeah, I know there were, one of you had typed in a question specifically about how many months ahead of time. And so again, this will be something, it sounds like your own facility, or look for your state guidelines or local guidelines and how to handle that. I think that we're in this learning phase as we all try to come up to date with these recommendations. And I've just learned a lot by hearing, you know, the stress really is about, you know, designing your policies or trying to work with your state or local TB departments if you're not in a TB control program, but work with them to develop something that's in line with local policy. I see that there have been, I see first of all as well, we have Paul Jensen, who is, I think many people know, an infection control guru from CDC in the Division of Global Health. You know, Paul, certainly we welcome if you want to *6 and unmute yourself and chime in, please feel free to. But anyone else from the audience with a question who's now unmuted yourself and would like to ask?
Yes, hi, this is Michael. I'm calling in with California, and going back to your previous question/comment about Cal OSHA and what we're doing here in California. So really quickly, Then in California, the healthcare worker falls under two regulations, one under Title 22 and the other one under the CalOSHA, or the Aerosol Transmissible Diseases Standards. So with just a week or two, the Title 22 licensing and certification issued an all facilities letter allowing facilities to submit program flexibility, but there's a process that that healthcare facilities need to go through in order to do that. And as far as the CalOSHA regulation, CalOSHA is currently working on an update to their policy, but we don't know when that may or may not happen. So that's kind of a quick summary of what's going on in California. So the regulations still apply to CalOSHA here in California, and for Title 22, for folks on the line, they can work with their district licensing and certification for possible flexibility.
Thank you so much. I appreciate you joining in. And I believe Kelly was pointing out as well that CTCA does have some information regarding this, the California TB Controllers Association. You might also turn to their website. Well, I know we have our last few minutes. Any closing thoughts or comments from our faculty panel? I'm going to leave it open to you now that we've had so much information out there. Lynn, Bob.
Yeah, I was just going to say, thanks to all the folks who joined in and participated. It really was active chat session and questions coming in, and we appreciate that. And it took a long time, as Lynn outlined the timeline, to just get what we got in terms of updating that small portion of the 2005 document. And even and even with what we did, there were so many questions that we couldn't address in that, and so it's conversations like these and questions and discussions that's going to continue to move this forward. So I really appreciate everyone who took the time to join today.
Well, thank you, Bob. I mean, I have to tell everyone who's listening, just going through the process of developing this webinar and going through our phone calls and our rehearsals, I've come to appreciate, how much change this is going to really represent in terms of our day-to-day practice as programs. And so really kudos to this group for bringing this to light and to be continuing to work on the practical advice through the companion document. And you can see through all these questions that is going to be extremely useful. And I think this discussion will just keep going and going through more webinars in the NTCA and all the different partners that contributed to this process. And again, thanks so much to the faculty, and thanks to all of you listening.